Hey guys, can you hear me?
Yes.
Okay, just making sure. I'm using a different computer and I just wanted to make sure you could still hear me all right. Okay, it looks like there's like 2 minutes to 6, so I'm just gonna start here in a couple minutes and we'll go from there. Um, so my plan, I'm just gonna kind of like focus you guys a little bit on what um, to look at more for the test to get ready for it, and then we'll see what you remember about certain things we talked about. And then I have a little Kahoot thing that I made that we'll just try to do that, see how that works for you. Any specific questions about anything while you're waiting on me to start?
I get kind of confused sometimes on when to use the dry and the wet the suction the machine for
Yeah,
the
don't
vet.
focus on that
Okay.
because that's not the most important thing to know about chest tubes. Okay. So
Okay. Okay.
honestly, it's the surgeon's preference on which one is used.
All right.
So it's really not, oh, I need to grab this one over that one. It's nothing like that. So
Okay.
don't worry about that.
Okay, thanks.
They both do the same thing, really. It's just they're set up differently. That's all.
Okay, thank you.
Uh-huh. Okay, so let's go ahead and get started. Now, when you're studying for this test, I know we went over a ton of information and it's overwhelming. I get it because we did it in such a short period of time. Now, if it was up to me, obviously we wouldn't go through things this quickly. It just sucks. We only have class for one day and it's just not the same online here as it would be in class either. So, the biggest things that I really want you to focus on for this test is COPD and asthma, because you're going to have probably the majority of questions on that. So, what can you guys tell me about asthma? What are some things that you remember about asthma that are important? If I had to say, what are some things that could cause you to have an asthma attack? What could trigger that? What would be some things that you guys would say?
Allergens, right?
Sure, any type of allergen. Like, give me some examples of more specific things.
Dust,
Dust, okay.
Pet dander, dandruff,
Smoking.
whatever.
Yeah, pet dander's a good one. What else?
Smoke.
Smoke, yeah, that's a good one. Sometimes even like perfume or anything, like that. Did I tell you? I don't know. I can't remember if I told you guys that story or not. I probably did. But this lady that was doing an orientation for me for clinical one time, she thought someone had perfume on in the room, and we were all looking at each other like, no one has perfume on. What is she talking about? But she smelled something, and it totally made her go into an asthma attack. So yeah, perfume is a big one. Um, don't forget that foods can cause allergies as well and also can cause an asthma attack. You can actually have a trigger that's a food. Also, there's certain medications that could do it. And then you could also just be sick. Like you have asthma, and then, like, say you get some kind of respiratory infection or something, that can cause you to go into it as well. So there's a ton of different things. So just really focus in on that type of stuff. And then with asthma, what are some of the signs and symptoms that are like, oh, that's asthma right away when you would look at a question? What would you say?
Wheezing.
Definitely wheezing.
Um, Difficulty breathing and sometimes coughing.
Okay. You could even have chest tightness that goes along with that. Like my one son was diagnosed with asthma a while ago, and he wasn't really having like wheezing and all this other stuff, but he was having like a tightness in his chest. It was kind of a weird, vague feeling, and that's what it was. just think of, someone who can't breathe real well. So, with asthma, we have basically like three different things that are happening at the same time. So when you have one of those triggers that causes you to go into your asthma attack, you're having your airways are tightening, like, so like, how you have muscle that's surrounding your airways. So the muscle's tightening down. You're also having inflammation inside the airway. So the stuff inside the airway is swelling up. And then you're also producing a ton of mucus at the same time. So all three of those things are happening. And as you're trying to get air through those airways, that's why you hear the wheezing, because it's having such a hard time getting through. So, keep that in mind, like what's going on pathophys wise too. Okay, so if you're having an asthma attack, what's the first thing that we would probably give you for that?
Albuterol, something like that.
Definitely probably albuterol. So albuterol is going to be the bronchodilator. So that's probably what we're going to give 9 times out of 10 first thing. So that's going to open up your airways, make it easier for you to move air. What else could we do for someone with an asthma attack? It's like, say this is a really bad one, and maybe you're giving this person albuterol and it's not really taking care of it completely. What else could you do for them?
Can they get this? Is this where you can give them steroids too?
Yes. So in an acute episode, if I'm hospitalized for this asthma attack and it's like really bad, just think of what we just said with those 3 things that are happening. You're having all that swelling. So maybe that's what you need to do. You need to give them something to get all that swelling down. So if you give them a steroid, that will help for sure. And you would do it for a short period of time and you would taper it down, right? Why do we have to taper down steroids? What does it do to you if you're on a steroid for a long time?
To be honest, I don't remember. I was hoping someone would say something.
Okay, I was going to say, wait a minute, no one's talking. All right, so when you're on a steroid for a long period of time, it does a number of things to you. That's why we don't want to do this, right? So it can cause you to gain weight. It can cause you to be more apt to get sick, like your immunity level goes down. There's like a whole list of things that can happen. You can get some adrenal insufficiency that goes along with it. That's like the biggest reason why we don't want to take it for too long. Yeah, there's just a lot, whole list of things. So if there's any drug that, obviously I want you to know albuterol most of all for this test. And I'm telling you, I don't have a question on here about, prednisone or anything, but this is something you need to know. You need to get this down now so for the future, you don't forget this ever, because you'll see, steroids used all the time for different things. So you need to get that in your head, why that's not something that you would want to be on for a long period of time. So make sure you look that up and really know that drug. Okay, so that's kind of the big things with asthma. Just be aware that too, if someone has like a really bad episode, if they're out in the community somewhere and they have an asthma episode and it's really bad, they probably have an EpiPen, So you could always give an EpiPen too in that situation and then take them to the hospital and get them better controlled as well. So that's something to think about too. All right, I'm trying to think what else with the asthma. Oh, so do you remember when we did that whole case study thing with asthma, which you guys should have done that on your discussion board? So remember we talked about the asthma action plan with the green, the yellow, the red, and how green is where you want to stay. Yellow is when you're starting to have a little bit of symptoms. Red would be when you're really having a big issue. And then we talked about peak flow, right? What's a peak flow meter?
It measures like all the total volume of your lungs, like when you blow out, right?
Yes. And so someone who has like moderate to severe asthma should be using a peak flow meter like daily, right? So if you're someone like my son who doesn't really have it too bad, then he doesn't have one and he doesn't do it. But if I was someone who really had an issue with this, then this is something I should be doing all the time. So typically you would do it in the morning when you get up, and you want to get your reading and see where you're at, because you remember on that action plan it has best, I forget how it's worded, but best overall reading or something, and you kind of go from there with that. So this kind of helps you keep track of your asthma so you don't get into trouble. So it gives you kind of direction on what to do next if you're having a problem, right? So that's definitely important to know. And then the next thing I want to talk about is COPD. So COPD is a little bit more complicated than asthma. To me, it's kind of harder to grasp, than asthma. What do you guys know about COPD? If you had to describe what is it, like a definition of it, what would you say?
Isn't it like two different conditions combined, like emphysema and bronchitis?
Okay.
That's all I remember.
Anyone else have a thought?
Is it when um like your elasticity is gone in your lungs from too many incidences where you have a hard time getting air in and out because of the swollen lungs?
Okay. You're both kind of right a little bit here. So with COPD, the biggest number one cause of COPD is what?
Smoking.
Smoking, right? So other things that could, kind of cause it would be, any kind of exposure to pollution or secondhand smoke or asbestos or anything along those lines, right? So if you're having all of this exposure to all these crazy chemicals over time, it damages your lungs. And so this person, like you said, you can have all this inflammation going on. So it's kind of similar to asthma in that way, where you have this inflammation, so it's harder to get air through. But then over time, as it gets worse, you're actually damaging your lung. And so the damaged part is down towards the alveoli. And so you remember the alveoli is where we have that good gas exchange between the blood and that, right? So you can get oxygenated blood and get rid of, the carbon dioxide and stuff. And so this person, they don't have a hard time breathing in, but they have a hard time getting all of their air out. So they get trapped.
Yeah, I'll go get it.
So they get trapped air in their lungs, and they just constantly feel very short of breath, right? So Brandon was right too, because you can have both, like a little bit of emphysema, a little bit of bronchitis. So what if someone told you to describe bronchitis, how would you describe that? I'm sure you guys all have known someone who has had bronchitis before. What do they look like?
Well, bronchitis, you just have like hard breathing and lots of phlegm and mucus and stuff, right?
Yes, and you cough a lot, right?
Oh, yes.
So that type of person, like he said, you have all this mucus and you just really have a hard time with this cough. And so I don't know if you guys looked at those things that I posted, those pictures, but there's one called the blue bloater and one called the pink puffer. The blue bloater is the bronchitis person. So this person, they're not ventilating well. So this means that as they're trying to breathe in and out, they're becoming hypoxic because they're blue. Okay, so they're, if their skin coloring isn't quite right, they're not ventilating well. So this person, they're having a hard time getting air, out, so air is trapped in their lungs and they have all of this inflammation and stuff. So as they're breathing, sometimes you'll hear a lot of crazy lung sounds from that. Now, the emphysema person is the pink puffer. So this is the person who looks really skinny and just sickly like. They're the person who is more short of breath. Like if you had to compare the two, they're more short of breath than this bronchitis person is. And they are always anxious. And so they're the person that you would probably see, hunched over their bedside table in that tripod position. They just look really crappy. They don't have the coloring problem with being like bluish. They're more like a normal color, but they can't ventilate well either. So you'll have people who will be a little bit of both sometimes, and then you'll have some people who have more of one problem than the other. It varies, person to person. But the whole point with COPD, you need to know, hey, what are some causes? What are some of my symptoms that I see with COPD? So if you had to name symptoms, what would you name for COPD symptoms? What are some significant ones that are different than every other thing you've heard about?
Barrel chest?
Barrel chest, definitely. So why do you have a barrel chest if you have COPD?
Because air gets stuck in the lungs.
Yeah, so
Kind of.
because they're having such a hard time getting air out, they're constantly hyperinflated, their lungs are, and so their ribs just kind of stay there over time. And so now your elasticity of your lungs isn't quite the same, so it just kind of stays that way. What else?
Wheezing and, stuff like that.
Okay, so I'm going to tell you guys something about the test. There is one question that is going to ask you about lung sounds, and it has to do with emphysema. So remember what I just said about there's a teeny bit of a difference between someone with bronchitis and someone with emphysema. So the person with emphysema is the person who has more damage to their actual lungs. So the damage, at the alveolar level is causing them not to ventilate well. So what do you think their lungs are going to sound like? If you're not ventilating well, you're not moving air well. So if you're not moving air well through your lungs, what do you hear?
Diminished sounds?
Yeah, exactly. So I just felt like it's kind of a difficult question. And after I looked at it a couple times, I'm like, I don't know if I should put this on here. But yeah, you're right. So if you're not moving air well, you're not going to hear much. So whereas the person with bronchitis, remember we said they had a ton of mucus and all this stuff. What do you think they would sound like?
Like you hear like crackles and things like that, right? For the fluid?
Yeah, like crackles or rhonchi or something like that. Yeah.
Okay.
Because of all of that extra mucus and stuff in there, for sure. Okay. So just kind of think that way when you're looking at these questions, because there's a couple things that are going to ask you, like assessment wise, what someone would sound like with certain things going on. Okay. Let me think. I'm trying to think of the other ones. Hold on one second. Let me pull this up real quick. I'm just trying to think of different things to help you out here. Hold on. So like, oh, I know what I want to ask you. Okay. So people with COPD, you know how they can have exacerbations and remissions. So when someone has an exacerbation, what sets them off to make them have this?
Anything physical, like climbing stairs, running around, ambulating,
What about being around
maybe?
sick people? So when you have COPD, you should stay away from crowds and people who might be sick because you pick things up at the drop of a hat. And when you pick that up, it's harder for you because your lungs are already messed up, you know, so it's harder for you to get rid of it. So typically that's what will set them off into an exacerbation. So kind of keep that in mind when you're looking at questions as well. Okay, so again, the majority of questions are going to be asthma, COPD, because when you think about NCLEX and when you're looking at NCLEX questions, that's going to be most of what you see for, you know, that kind of stuff. Now, it doesn't mean other things aren't important. There's still some other things that are important, but that's kind of the bigger portion. So that's why I put a lot of those on there. Now, a couple other things. I put a little bit about laryngeal cancer on here. So remember when we talked about that, we said your larynx is your voice box. And what's inside your voice box? Your vocal cords, right? So this is how you talk by you know, having your vocal cords and sound traveling through there, right? And so if you have laryngeal cancer, sometimes it can start out little where maybe you just have like a tumor on your vocal cord or something. And remember that on that one PowerPoint, I have 3 million things listed for, you know, treatments that they could do for this. And there's some like vocal cord stripping and I don't know, there's a bunch of other things listed there. So as this gets worse and it gets bigger, you have to do more, you know, to try and treat it, right? So there was one that was a partial laryngectomy which has very good results. But with that one, you kind of preserve your swallowing ability and you still have a little bit of a voice left afterwards. So your tumor isn't as involved, so it's easier to get rid of that and still kind of preserve some of that stuff for the person. However, if you go to a total laryngectomy, now your tumor is more involved. At this point, you're taking out their tumor and you're going to take away their ability to speak and their ability to swallow the normal way. So now their airway is at risk here. So you have to put in a trach when someone has a laryngectomy. So afterwards, you know, they'll have the hole there for the trach and they won't be able to talk. So what are some things we can do to help them with that?
Like you mean to help people communicate who can't communicate?
Yeah, I mean, you could look at it that way, but there's actually some things that you can do, some procedures that you can do afterwards to try and, you know, get them to be able to communicate again.
You can use that. I can't remember. It's like some sort of valve that you put in the throat inside the trach, or without the trach actually.
Yeah, so there's a procedure called a tracheoesophageal puncture. That's the one I want you to remember. So with this procedure, they kind of, they do some kind of weird bypass with everything in there so that afterwards this person could have some kind of device that they put over top of that area to be able to kind of produce some sounds now. So this person would be able to speak a little bit eventually. Typically they have to work with a speech therapist for a little bit and then eventually they can actually have a voice and stuff afterwards. So they could do that during that surgery, the initial surgery when they do the total laryngectomy, or they could do it, you know, weeks later, whichever, you know, they prefer. When you're doing the reading in the book about the total laryngectomy, they talk about a couple of other things you could do. I'm sure you guys have all seen that one commercial with that lady who has I don't know, it's for one of the American lung cancer commercials or whatever. She talks about, she looks kind of funny, and she talks about how she had lung cancer, and then she has this little device that she puts next to her neck right here, and it makes like a mechanical sounding voice. So that's different than the tracheoesophageal puncture. Those are two different things. So this one, you sound more mechanical, almost like a robot. The other one is different. And then the book also talks about this one way that you can try to talk, which is almost like burping, which is weird. I would never want to do that. You know, can you imagine trying to communicate with people and you're burping everything you're trying to say? That's just crazy. So yeah, so you need to know some of those types of things, and then just be aware that it's going to be very emotionally hard for this person after surgery, because that's, you don't think about it, but not being able to talk would be horrible. So it'd be very depressing, and you need to think about ways that you can help facilitate this person to still be able to communicate. So whether it's through, you know, writing things down or like a communication board or whatever, right? What would be another focus after this surgery that would be super important? Like with your interventions.
How to take care of it, how to clean it and everything.
Clean what? Are you talking about the trach?
Yeah.
Okay.
How
Yeah.
to clean the area, the stoma, how to take care of it.
Okay. So what I'm trying to get you guys to say, airway is a super huge, important thing that you have to focus on after surgery, their airway. So you're always worried that this person's going to aspirate or that they're going to have an issue with their airway, because you've manipulated all of that in that area now. So they could have a lot of swelling, they could have lots of things that could happen afterwards. So imagine, you know, if you had a ton of swelling there, what would your, I don't know, if have you guys ever heard someone have stridor before? Or do you know what stridor is? So basically, stridor is when you have an obstruction of your airway. So it could be because you have a bunch of swelling that it's totally closing up. So it's almost like wheezing, but
Is
it's,
that the one that sounds high pitched?
yes, it's similar to wheezing, but it's way worse. So like you would never have to put your stethoscope on them to hear this. You would just hear it because it's so loud and crazy sounding. Like you could probably hear it in the hallway. So this is no joke. When someone has this, it's a medical emergency. So pretty soon they're not going to be breathing anymore if you don't do something quick. So that's something that you would be worried about after this. So you're always just worried about this airway. So you want to make sure that, you know, this person's kind of sitting upright after surgery. They're not like laying flat. You're going to have a suction, you know, equipment available close by just in case they would, you know, be aspirating anything. You know, you think that way about the total laryngectomy. Okay. Let me think, what else did I put on here? So a couple other things. I did put a teeny bit of stuff on there about pneumonia. So what is pneumonia, you guys?
Fluid in the lungs.
Okay. So you can get pneumonia a few different ways.
Infection in your lungs.
Okay. And you can get it a few different ways. It can be viral, it can be bacterial, it could be fungal. There's a bunch of different ways, right? And so, you know, our body is set up in such a way that we kind of fight off germs a lot, right? So like you could just inadvertently suck something up through your nose and breathe it in without realizing what it is. And it's a, bad thing that your body doesn't want to get in. And so like we have that little cilia inside our respiratory system to try and like filter some of that out. And sometimes things just get through no matter what you do. Your body tries to stop it, but sometimes it gets through anyway. So once it's in there, it starts to, you start to get fluid that builds up in your alveoli in your lungs. And so you're going to start, having crackles. You're going to have a little bit of a temperature. Sometimes you have a cough that goes along with this, a bunch of things like that, right? And then what's the one thing that older adults do with pneumonia that is different from everyone else? How can they present with pneumonia differently?
Is it confusion?
Yeah. Yeah, so they just may look confused and you're not quite sure what's wrong with them. And then once you work them up, lo and behold, they have pneumonia. So remember that. And then remember when we talked about this, we talked about community acquired pneumonia, hospital acquired. What's the difference?
Community is you get it when you're not in the hospital, like in your home or out in the environment.
Okay.
And the hospital is from ventilators or some other source.
Well, not necessarily the ventilator. It could be, but not necessarily. So the hospital acquired, what I want you to remember about that is you come into the hospital for something totally not related to pneumonia. So like maybe I'm in for a surgery of some sort. And then 2 days later, I start to have symptoms of pneumonia. That's hospital acquired pneumonia. So, a couple days have to go by before you start to develop those symptoms. And that's kind of defining characteristics of that. And then you're right, there is a ventilator assisted pneumonia that you could get. Oh, I'm sorry. What was that, Nick?
I said, isn't it like a couple days after you leave the hospital that it counts too?
Yes, it can. Yeah. Now, you're right, you can get a ventilator assisted pneumonia as well. And that's, we kind of mentioned a little bit about teeth brushing and how that's supposed to be very important because bacteria can get all in your mouth if you don't do any kind of mouth care. And, when you're ventilated, you have an ET tube, that endotracheal tube that's, down your throat. And so all of that bacteria can get on that ET tube and it can travel down into your lungs. And that's how you can easily get pneumonia. So if you do really good mouth care and try to, brush their teeth and do all of that, it kind of helps prevent that. Plus, getting people off of a ventilator as quick as you can is always a better thing too. Because the longer someone's on a ventilator, the more chance they are of getting that. What's the best way to prevent pneumonia in people?
Like high Fowler's position, being active, coughing.
You're thinking too much.
Early,
It's simpler.
early ambulation and the incentive spirometer.
It's simpler than that, but that's a good one.
Is it just the ambulation in the incentive spirometer?
It's getting vaccinated for pneumonia. That's what I'm thinking. It's vaccination.
Oh, jeez.
Okay. So you guys are right in your thinking about some of the things that can help prevent it, definitely. But the best way to prevent pneumonia is to be vaccinated. So, that's going to be, giving you way more protection. Okay. All right, let me think what else. I do have a little bit about pulmonary embolism on here. So remember we said a pulmonary embolism is a blood clot that forms somewhere in your body and it lets loose and it lodges in your lung. When it lodges in your lung, it's making you not be able to breathe very good anymore, right? And so what kinds of symptoms do you have when you have a PE?
I think I remember chest pain was one.
Mm-hmm.
Wasn't back pain one too?
It could be.
Wouldn't your stats be low, like O2 and whatnot?
Yes, definitely. What else? Just think about it. I'm sure you've all had a time where you couldn't breathe.
Shortness of breath.
So when you can't breathe real well, you get anxious, right? So they're going to have real high anxiety. They're going to be breathing really fast because they can't breathe, right? So they're going to have tachypnea. They're going to have a high respiratory rate. They're going to have a high heart rate usually. And then remember I said something about feeling of impending doom? A lot of times patients will come out and tell you, I feel like I'm going to die, or I feel like something's not right here. They'll be real specific about what they say. And you always have to take that seriously because usually they know when something's wrong. So that feeling of impending doom is definitely a big thing with this. All right, and then remember we said that if you don't take care of this kind of quickly, you know, this can really spiral out of control really fast, especially if it's a really bad pulmonary embolism. So sometimes people get one that is really big and it can cause death really fast, like within an hour if you're not quick about things. So some of the things that they do to try and figure out if you have a PE would be, remember, spiral CT is the, you know, gold standard, or, you know, CT angiogram, you know, that's another word for that. So basically they take you for a CAT scan, and this CAT scan lights up everything in your lungs to try and see how like the blood flow is in your lungs. So it'll pick it up if you're not getting good blood flow somewhere, you know, so then you'll know for sure. If you can't get a spiral CT, and remember for a CT like this, you get dye, you know, you get the IVP dye, so everything lights up so you can see where everything is going. And so if you're not able to get dye, then you can't have a spiral CT. So then what's the other test that you would get in its place? Remember, this is a VQ scan. And the VQ scan is not as accurate as the spiral CT. So the VQ scan might say, oh, you have a 45% chance of having a PE. So if you really suspect that this person has it and then the results are kind of iffy like that, they still may treat you for it anyway, just to be on the safe side. And what do we do to treat a PE? What do we give people?
Antithrombolytics.
That is an option, but that's not the first thing we do.
Anticoagulant.
Okay, what thing do we do first? You're right, but what kind of anticoagulant would we give first?
Heparin.
Heparin, right? So we start them on a heparin drip. And so remember, you would do that because what does heparin do for this clot? Does it get rid of the clot?
Keeps it from getting worse.
Okay, so it keeps it from getting bigger, and it also keeps you from getting more, right? So
Yes.
then what would we do after the heparin? So then we would have to, obviously you can't go home on a heparin drip, so you have to put them on another type of anticoagulant, right? So it's either going to be Coumadin or one of the other newer ones like Eliquis or Xarelto or something like that. So typically you want their INR level to be around 1.5 before you take them off that heparin drip. So you're always going to be drawing those blue tubes of blood because that's the coag levels. And so not only, with heparin drips, we're mainly looking at the APTT, right? But you can also do the whole 9 yards with the blue tube of blood. So like you can look at the PT and the INR as well with the blue tube. So we're trying to get them to a place where once we put them on the oral, that they'll, their INR will shoot up some more because we want their INR to be between 2 and 3. So that's a typical way that we treat PE. But then if this person is very unstable and they're having really bad blood pressures and really looking really bad, then we may not do this. We may take them right to surgery and do an embolectomy, right? So the embolectomy is where they go in and they actually remove the clot. So that might be something that you see them do. Or if they're not a good candidate for surgery for some reason, then maybe they would try to do the thrombolytics like Brandon was saying. So remember, thrombolytics are like Retavase and Alteplase. Those would be some examples. And this is something that you would get through the IV in an ICU type of a setting. And remember, thrombolytics are the only thing that can dissolve a clot. So, you might try that route if this person wasn't a good surgical candidate. So how long do you think you have to be on anticoagulants after you have a PE?
Is it maybe like three weeks or so?
A little bit longer, 3 to 6 months. You have to be on oral anticoagulants after a PE.
3 to 6 months. Okay.
Mm-hmm. Yeah. Okay, so I'm trying to think. There's probably like maybe three questions on PE. There's not a ton. And then we talked a little bit about TB. And so I don't think I have a ton on that either. There might be like 2 or 3 on that as well. So there's something about testing for that on there. And I think there's something about like treatment of TB. There's questions on that. Let me think. What else is on there? Oh, there's a little bit about lung cancer on here. So a couple of things actually about lung cancer. So you remember when we talked about lung cancer, we said there's a few different types. We talked about non-small cell versus small cell, right? And the non-small cell like broke up into even more groups of different types, right? And we said that which one was better than the other one to have? Like if you had to choose which type of lung cancer you had, which one would you want over the other one?
I think small cell.
Opposite.
rather
Non-small
have?
cell. Non-small cell you
Oh,
want.
non-small.
Non-small cell's the one that broke off into 3 other types. It had adenocarcinoma and squamous cell and some other stuff in with it. So you would rather have that kind because some of that you can actually surgically fix. You can go in and take it out by surgery. Whereas the small cell is a little bit more aggressive. So unfortunately, with someone with that, sometimes by the time you figure out you have it, it's already like metastasized somewhere else. So that's a little bit worse. And remember, we gave percentages and stuff, like usually there's more non-small cell type cancers that you find compared to the small cell. which is good. You don't want to have a ton of those, but really your chances are a little bit better with the non-small cell. You tend to do a little bit better. So like there's questions on here about the different types and like how you treat them differently. So I think there's one, this is something about how do you decide for how you're going to treat someone with cancer. And remember when we talked about this, we said it kind of depends on the type of cancer it is. It depends on how sick this person was to begin with. Like maybe they have a bunch of comorbidities and they're already super sick as it is on top of getting this, then they're not going to have really good chances, right? But if there's someone who doesn't really have a whole lot wrong with them and then they get this, then they're probably going to do better, right? And then they have to do that that staging of the cancer to see like what stage it's in. So usually if you catch it quickly, like stage 1, stage 2, usually you have better chances. You can maybe get it out surgically, you can do chemo radiation and be okay. But if you get it when you're stage 3 or stage 4, your chances aren't as good because now maybe it's spread to other places. And maybe now you have to just do like palliative care or something, who knows? So there's some questions kind of along those lines with that stuff. What's a pneumothorax, you guys?
Punctured lung.
Collapsed lung.
Okay,
Or yeah, collapsed, not punctured, sorry.
so if you were looking at the lung, I wonder if I can draw this. Let me see if I can try it. Let's see. Oh, geez. I'm not doing a too good job here. All right, so here's lungs right here.
Listen, we're not judging you. Just have fun.
It's hard to draw with this thing. And I don't have a mouse on here, so I'm doing this with my finger. All right, so there's like a little area in between the outer portion of the lung and like where your lung is. So like this inner portion here is your lung. And then you have this space that's in between right here. And you know how lungs have surfactant in them, like automatically to kind of help so that as your lungs, when you inhale and exhale and your lungs go in and out, that you would have all that rubbing there in between those areas if you didn't have a little bit of fluid, right? So you have a little bit of fluid in here automatically, but it's not a huge amount. So when someone has a pneumothorax, they have a collapsed lung. So that means that maybe, let's see, maybe like, oh darn it, I just got rid of that whole thing. Well, like a little portion, gee whiz, nothing's working. Anyway, I was gonna erase like a little teeny portion of that. So that part of the lung isn't working anymore. Oh, that's this will let me redraw. No, darn it. All right, so much for that idea. So anyway, like I said, that you have that little outer portion surrounding your lung. So when you have a pneumothorax, there is either air or fluid or something that is kind of like pushing up on your lung. It's accumulating in that space around the lung, and it's causing the lung to not have very much space to expand and contract. So this person will have shortness of breath, they'll have chest pain, you know, all of that because of this pneumothorax. All right, so what do you do for a pneumothorax?
I know like the one thing you do is like chest tube.
Yeah, that's what you do, a chest tube. So
Oh,
when
I
they
thought
put
that was something else.
when they put the chest tube in, they don't stick it in the lung. They put it in that little space outside of the lung, like I was trying to draw just now. So it would be in there. Because remember what I said, because you have this accumulation of either air or fluid in there, it's making the lung not be able to expand like it should. So when you put the chest tube in there, it's getting all of that out that doesn't belong there anymore. So whether it's air, getting the air out, or getting that extra fluid out of there. So like, when we say hemothorax, that's a collection of blood in that area. So maybe like you had chest trauma or something and you have, bleeding in your chest, then that could be accumulating in there. So the chest tube would be able to get rid of that. So it fixes it over time. And so after you get rid of all of that, you can take the chest tube out and then the lung will be able to expand and contract like it's supposed to. So what do you remember about chest tubes, you guys? What are some reasons why you would get a chest tube? Other than the one we just talked about.
To plug a leaky hole in the lungs.
Well, it's for pneumothorax, but what else is it for?
To keep pressure, like to make sure the pressure is maintained.
That's a good guess. It's so anytime you have like open heart surgery, you're going to come out with a chest tube. Anytime you have lung surgery, you're going to come out with a chest tube, right? So that would be another reason. So surgery. What else? What else do you think? How about just if you have chest trauma, some type of chest trauma where like maybe you had an accident or something like that, anything traumatic like that where maybe you have broken ribs or something like that even, they would put the chest tube in there to help stabilize all of that. So we did talk a teeny bit about flail chest. And the worry with flail chest, which remember what that is when you have 2 or 3 broken ribs in a row. And the worry with that is with the broken rib that maybe it's broken in such a way that it's going to poke a hole in your lung and cause you to have a collapsed lung. So if that's the case, again, they would put a chest tube in, right? Now with flail chest, there's not a whole lot that you have to do as a nurse for someone like this. It's going to be very painful, of course, because it's, broken ribs. So this person is not going to want to cough and deep breathe like they're supposed to because they have these broken ribs. So you may have to suction them at times. You may have to, give them lots of pain medicine and still encourage them to do their incentive spirometer and things. But generally, you don't really have to like try to stabilize that or anything unless it's a big problem. So like they'll do some type of imaging on that and they'll see if it's something that needs fixed. If it is, they would take them to surgery and fix it, or they may have to put them on, mechanical ventilation for a little bit if it's a big problem. But most of the time it'll heal on its own. All right, so what's the normal setting for a chest tube? When you see like an order from a physician, what do they usually tell you to put it at? No one remembers this? This is 20 centimeters of suction. So sometimes you'll see it written negative 20 centimeters of suction. Sometimes it'll be written 20 centimeters H2O. It all means the same thing. Okay, so there's different settings for the chest tube. And remember, with the two different types of atriums that I was trying to tell you about, with the dry one has that dial that you can dial it up to a different type of suction. So it doesn't have to be at 20, it could be at 40, or it could be at 30, or it could be at 10 with that one. With the wet one, it only has the one setting. It's always 20. So just remember, that's the most common setting that you'll ever see. The only time you would ever have to set a chest tube at something else would be if someone was having a problem. Like maybe they had that crepitus. You remember when we talked about crepitus in that PowerPoint when we showed that picture of that guy with all that swelling in his face? If this guy was having a big issue with that and you were worried that this crepitus was getting too bad, then maybe the surgeon or the physician might tell you to turn the suction up to a little bit higher of a setting. Sometimes they'll do that. But generally, you don't really mess with that setting too often. What do you do if you walk in and someone has accidentally pulled out their chest tube? What are you supposed to do?
You cover it with gauze and a saline.
Okay. So you cover it with a sterile dressing, right? So you would reach for like a sterile 4x4, stick it over the site, tape it, and then you would assess your patient, make sure your patient's okay, right? So what are you worried about when the chest tube comes out? You're worried that
Them
they're
not being able to breathe.
yes, you're worried that their lungs going to collapse and they're going to get really hypoxic and stuff, right? So you're going to listen to their lungs and you're going to see how they feel and get their vitals and stuff, right? And then you would definitely call a physician. And then usually a physician will probably order a chest x-ray just to check and make sure everything's okay with that. So that's usually what you will do. Now remember, for your purposes for tests, you don't have to worry about this, but just remember for in the future when you're working, there's two different ways that things can happen. So someone can pull it out all the way, from where it goes in at, or they can pull it apart down a little bit lower. So like maybe they still have their chest tube in place, but it's just pulled apart. If that's the case, then what would you do? Think back to your module that you did on ATI. What did your module say?
Don't you put it in sterile saline?
Yes.
Sterile water?
Yes. The idea is by doing that it makes a water seal because you're putting it in water so it seals it. And so you would hope that it would make you not have a collapsed lung if you do it quick enough, So until, everyone can get things put back together. So that's kind of the difference. So if it's pulled out all the way, from the skin, the whole thing is pulled out, sterile dressing, call the doctor, assess your patient. If it's, just pulled apart down lower, put it in some sterile water. Okay? So those are kind of important things to know about chest tubes. All right. There's probably a couple other things that are on here too that I didn't talk about, but I'm going to go ahead and show you the Kahoot thing that I made. You guys can play that real quick and we'll call it a day here. Let's see here.
Someone has a bee emoji. I love it. I forgot we can do emojis.
I don't know if there's anyone else who wants to play or not. Is that everyone? Okay, I'm going to start. Okay, what's the most likely history for someone with a pulmonary embolism? So remember, the recent surgery is really a big one for this. And remember, it's specific types of surgery too. Do you guys remember what kind is more at risk for this?
Long bone.
Yeah, so like a lot of the orthopedic type fractures, and then also anyone who has any type of like hysterectomy type of procedure or gynecological procedure, they're at risk for this a lot too. What's the main symptom of TB? Okay, so this one, you're going to have this cough that just lasts forever. So 3 weeks or longer. And typically you're going to have other stuff that goes along with that, like, bloody sputum that you cough up and the night sweats and the whole 9 yards. What does a positive TB skin test mean? Why is this not going forward?
Okay, I thought it was just me.
Hold on, let me see if I can recover my page. It just says Kahoot is not responding. Oh, shoot. Maybe we have to start over.
Yeah, it kicked me out.
Oh, all right. I guess let's try that again. Sorry about that. All right, let's see. Hey, it gives the same questions, so now you should get them all right. Look at this. Woo! All right. Good job. Main symptom of TB. Okay, good job. All right, I think this is the one that we had a problem with. Hopefully this goes this time. There we go. Okay, so the skin test, if it's positive, it just shows that you've been exposed to it. So you may not have the actual active TB at that point. What's pneumonia? All right, so you do have fluid in the lungs as well, but this is, so these are just pre-populated questions that I pick from, so it's not the perfect question, but inflammation in the lungs caused by viral, bacterial, or fungal infections. Okay, what is one symptom of pneumonia?
I'm thirsty. It must be my pneumonia.
All right, good job. Okay, COPD can be caused by everything except okay, so asthma will not cause COPD, so all of these other things could. COPD is a combination of which two diseases? Emphysema and bronchitis. Good job. Okay, why barrel chest occurs in people with COPD? Okay. What is a symptom of asthma? That picture kills me. They're having that dog do that inhaler. That's funny. Okay. The primary purpose of pursed lip breathing is to do what? Okay, so it helps get rid of carbon dioxide. So if you think about it, when you're doing that, you know, that totally would help you get rid of some of that trapped air that you have in your body. So yeah, you're going to get rid of some of the carbon dioxide. The nurse is aware that the best time to schedule a postural drainage treatment is when? Okay, so this would be in the morning when they first get up before they eat, because you don't want to do it in conjunction with them eating because that might cause them to throw up. How do you know a chest tube is leaking? Good. So you're looking in that water seal window, just like it was in that picture there, and it shows you the bubbling in that window. When do we use a chest drain? So talking about chest tubes again. Okay, for a pneumothorax. And that picture was way better than what I was trying to draw. So did you see how little that lung was on that side? That was because of all of that collection of fluid or air in that area around it. That's why it was so little.
Can
right
you
now.
click show media? I think it might pop up the picture again before you go to the next question.
Yeah.
Oh, sweet.
So all of this blue here is like either fluid or air that accumulated in there. So because all of that accumulated, it's making the lung not be able to inflate to the expansion that it should. And that's what's, causing the issue there. Good job, Jen. Wow. Okay, the nurse's number one priority following a laryngectomy would be what? And obviously a lot of these things are important, but which is most important? So the airway's more important than communication always, right? Because you always think about your ABCs. Doesn't mean that communication isn't important, because it is. Remember, we said those are two really important things after surgery, but the airway is always going to be top priority. Okay, patient 2 days post-op from laryngectomy, priority assessment should be what? So assessment of their swallowing, definitely. Because remember we said we're always worried about them aspirating because everything's different after that surgery. Okay, indication of tracheostomy. Why would someone need a tracheostomy, basically? Good. So yeah, every one of these things would cause them to need a trach, but prolonged intubation is a typical one. And I don't know if you guys understood what some of these meant, but poor GCS recovery, that's Glasgow Coma scale. So if you are, starting out at a low number, that's saying you're doing pretty bad. So typically, if you're not recovering real well, you need to be, having a trach probably. Okay, symptoms of lung cancer. Okay, all of the above. So definitely you can have every one of these. And then remember other things to think about with lung cancer. You could have unexplained weight loss, a change in your cough over time. Maybe it's like sounding different, like stuff like that. And then what's the leading cause of lung cancer? We should all know this before even looking. There you go, smoking. All right, type of breathing with flail chest. So if you're like, what the heck does paradoxical mean? If you're, I don't know if you remember that video I showed you guys of someone who had flail chest. Just think when you normally see someone breathe, what do you see their chest doing? You see it, coming in and out, right? So with flail chest, it's paradoxical. It looks movements where you don't normally see these type of movements. So it sucks in funny because of those, broken ribs there. Kind of like, it's another word for that would just be unusual movements. All right. And patients on Coumadin should avoid foods. So remember, we avoid foods high in vitamin K because vitamin K is our antidote for Coumadin. So if you're eating foods high in vitamin K, then your Coumadin isn't working because you're, giving the antidote for it, essentially. Okay? All right. It's funny.
Good job, guys.
Yeah, nice job.
I let you guys win on purpose.
Gee whiz, that's loud. Did you guys hear all that sound? I don't know if you heard the sound or not.
No, I didn't hear any sound.
Boy, I heard it in my ears. My gosh. Okay. So that's the gist of what I'm going to do with you guys. Hopefully that helped you a little bit. I was recording this the whole time, so I will post this, as soon as I can here. When I post these things, I have to literally upload it to YouTube, and then I have to wait till it loads on YouTube, and then I have to repost it onto Canvas. So it's kind of a long process. So sometimes if I don't post it right away, it's because I'm waiting for it to download. So anyway, anyone else have any specific questions about anything? So when you're looking at your chest tube stuff, focus on things like, hey, what are they for? Because there's always a question about, hey, why do we have a chest tube? What's the purpose of it? There's always one about emergency situations. So, hey, what if it comes undone or someone pulls it out? And then a lot of times there's something about the type of setting or, maybe about air leaks or something like that. So look at that type of stuff when you're looking at chest tubes. And I did post a couple of handouts on the announcements today that might help you with the whole air leak thing if you just look at those. And remember, we'll have 2 math questions on this test. They'll both be heparin questions. So that one worksheet that I gave you about heparin, I mean, if you guys just look at that, you should be fine. Any other issues or questions? Okay, well, thanks for coming, you guys. I'll see you on Thursday, okay?
Thanks for
Thank
your
you.
help.
Thank you.
Uh-huh.